Hi everybody, I'm Dr. Deed Harrison. I'm president of Chiropractic BioPhysics Seminars and Technique and also president of Chiropractic BioPhysics nonprofit, our spine research foundation. I know you've been following these videos, but there might be somebody that's brand new. So please check out our website for CBP Nonprofit at cbpnonprofit.com. What you'll see on that website is an overview of what CBP Nonprofit is all about. You can also access the individual studies that CBP Nonprofit has sponsored and or written ourselves. There's just about 155 of these today. What you can see on this site is the reference citations with their appropriate PubMed link or their indexed online source. Okay, without further ado, we're going to go through this week's CBP Nonprofit research publication video review. This one is one of my favorite particular papers. I was the co-author of this. It was back in my younger days. We were looking at a non-randomized clinical control trial on subjects with chronic low back pain. We did what we would call a trunk translation trial. What we noticed previously was that oftentimes people with chronic low back pain, they presented with offset of their trunk left or right, and we call that a trunk translation. No one had ever done a clinical trial investigating can we reduce this conservatively in a non-disc herniation and in a non-scoliotic population, and B, does this have an effect on chronic low back pain? So we designed this particular paper to investigate these issues, and without further ado, we're going to go through that. This was in the European Spine Journal in 2005, a non-randomized clinical control trial of Harrison mirror image methods for correcting trunk list, or what we call lateral translations of the thoracic cage relative to the pelvis in patients with chronic low back pain. By myself, Dr. Renee Caillet, Dr. Joe Betts, Dr. Don Harrison, Dr. Chris Kaloka, Dr. Jason Haas, Professor PhD Tadeusz Janik, and then the late Professor Bert Holland, PhD in statistics. First and foremost, let's look at the natural history of low back pain. We have to realize something here. Chronic low back pain is the #1 worldwide disability that we have. It is a major issue. It's not something to minimize. Oh, I just have low back pain, it'll go away on its own. Now, previously I presented this information several months ago, but I'm going to do it again in a slide. Chronic low back pain is a major health concern. It does not just go away on its own. Oftentimes you'll hear certain researchers, or you'll hear insurance companies, or you'll hear what we call medical evaluators of a patient say, oh, don't worry, you have chronic low back pain, it'll go away on its own no matter what you do. That's the furthest from the truth that is possible. Check this out. In studies, for example, these were in the European Spine Journal in the 1990s and in the early 2000s. You can look these references up in the particular paper that we're going through, our paper. Investigations have identified that up to 75%, that's 3 out of 4, patients with acute low back pain will continue to have problems and thus develop chronic back pain. This is acute back pain. Don't worry, it goes away. 3 out of 4, 75%, that doesn't happen. At 3 months and 12-month follow-up, this is what the studies have identified. 39 out of 188 subjects in one paper, that's 21% only recovered. That means 79% in this particular project did not recover at 3 months. At 1 year, 42 out of 177 or 170, that's 25% recovered. That means 75% of these subjects still continued to suffer with low back pain that's now chronic 1 year later. This one's a shocker. This was one of the longest term studies ever done. This is a 28-year follow-up on Finnish metal workers. This came out of the journal Pain in 2006. What they did is they reported on several thousand Finnish metal workers, and initially they evaluated and looked at their condition, looked at questionnaires, do they have low back, leg pain, etc. And then they followed them for 5 years, 10 years, and 28 years to look at what is the point prevalence and what is the longitudinal incidence of low back pain. Here's what they identified. Initially, 54% of their population reported low back pain. You would define that as acute. 25% reported radiation of pain into the lower extremity. That means leg pain. So we have just over half saying I got low back pain, and then 25%, 1 out of 4, having leg pain with that. Now, low back pain at the 5, 10, and 28-year follow-up. 75% of the subjects that initially had low back pain, 75% at 5 years continue to have it, 73% at 10 years, and 88% at 28 years. 88% continue to have low back pain at 28 years. Now just take a minute and think about that. You go, wow, I got pain now, don't worry about it. 28 years later, I'm 9 times out of 10 likely to continue to have this. That sucks. That's not a good thing for a person. The psychosocial ramifications of this are huge, right? You know, you don't want to scare somebody, but the reality of it is we find that 7 to 9 out of 10 people with low back pain continue to have it at these long-term follow-ups. Look at this. Leg pain, 2/3 to 69% continue to have the leg pain. This is not a pretty picture. So looking at studies that investigate new interventions or old interventions, how effective they are at low back pain improvement is an important thing to do. That's what this project set out to do. We're going to look at the short-term outcomes of low back pain by intervening with a new intervention. Okay, now when we look at people's posture, we break it down into rotations and translations. My late father, Dr. Don Harrison, taught chiropractors how to do this. Let's identify what posture a given patient or a given subject has. There's 12 simple postures that somebody can have. Flexion, extension, turning right, turning left, bending right, bending left. These are rotational displacements. Okay, these postures are abnormal when we identify them in your neutral upright stance. Here's the translations or linear movements. Left and right translation, up and down translation, forward and backwards translation. In this particular project, we're going to be isolating out the posture of left and right trunk translation and looking at what is the magnitude of this posture in chronic low back pain. Can we come up with methods to reduce it? And what is the effect on chronic low back pain? Now, first and foremost, let's look at this subject. You'll notice he went from happy to sad. Why? Well, his posture displacement is huge, right? You wouldn't be happy either if you looked like this. You have a big offset of your trunk. That challenges the low back muscles. That challenges the joints, the discs. It challenges the nerves. It is not a healthy position to be maintained. Now, somebody that acutely injures their back, they can have this antalgic type of posture due to the pain. We are not looking at subjects with acute injuries. We're looking at subjects with chronic injuries, chronic postural displacement, chronic back pain. These are not acute injured subjects. When we look at these subjects, we go, man, do you realize you're standing like this? And the majority of them don't even realize that their trunk is shifted to one side. What's the consequence on the spine? Well, your spine should be straight up and down from the front, but when you have a trunk translation, you're going to have a bend, a shift, and a little bit of a twist in there. So when we look at your spine on an x-ray, we're going to see your joints are bent and shifted off the midline, and when we take an x-ray, it's going to look something like this. This is the neutral position, straight up and down. This is what your low back should look like from the front. That's the normal spine. That's the ideal spine. People should be close to that. This particular posture, this trunk translation, you'll notice it will create a horizontal offset of the lower thoracic spine or the lower ribs relative to a vertical midline coming up from the center of the sacrum. Okay, the center of the sacrum is, in essence, the center of the pelvis on this x-ray. This vertical line straight up shows where these vertebrae should line up. And in this case, you can see we have a large offset in this particular subject. There's 29 millimeters of offset. 29 millimeters. How large is that? Well, put it in perspective. The maximum a subject can do is about 51 to 53 millimeters of horizontal offset. So we're roughly, in this particular example, we're roughly 2/3 of maximum in this particular subject. They're shifted over by 60% of their range of motion. Okay? So what we notice is this spine has a horizontal offset and it has a bending in there. The lower vertebrae are bent to the side of the trunk shift, and then the upper lumbar vertebra and lower thoracic vertebra start to bend the opposite way. In the literature, in the medical literature, this was called a wind-swept spine. That was just, terms for this. They called it a listing of the spine. We now call it a trunk translation and the associated spine displacement patterns. This is what it should look like. Okay, now here's the posture. This is my horizontal offset. It can be left or right. So we look at a subject's rib cage. We notice it's shifted linearly to either the right or the left. In this example, it's to the right. Okay, and then we match it to the x-ray. The x-ray should match that displacement. Now, just a quick note for the doctors out there and also the patients. This is not true scoliosis of the spine. This is what we call a pseudoscoliosis. You'll notice the center of the spinous processes here on this line, the spinous processes are not dramatically rotated to one side or the other. That's how we differentiate this from true scoliosis. These spinous processes are close to the midline of the vertebra. So this is not a true scoliosis. What it is the spine pattern that matches this offset of the posture. In a real patient, this is what it would look like. So here's a subject that we look at. This person has chronic low back pain, no leg pain, and we blocked out their face for identity purposes. This person, you can see, has a translation of their rib cage, their trunk, towards the left side relative to the pelvis. Now, oftentimes you'll get a slight high shoulder on the side you translate to. So we look at this and we categorize it. The left shoulder here is a little bit high, and that's on the side of the translation. You'll notice more space between the arms and the ribs and the arms and the waist, or the arms and the hips on the side we translate to. So this trunk is translated over to the side. Now, what does that do? Hey, that horizontal offset, your trunk without the arms, just the trunk, no head. If we just look at your torso, that torso is roughly 28% of the human subject body mass. Okay, you're shifting that off midline. There are consequences. In a 200-pound male, a 28% body mass, that means your trunk itself weighs 56 pounds. 56 pounds. If you shift that off midline, there are consequences. Your muscles have to contract to support that. That's going to load the lumbosacral, the lower low back discs. That's going to cause increased compression and shearing on them, and that will accelerate degenerative changes, leading to degenerative disc disease, leading to bone spur, and it will also lead to chronic mechanical back pain. Your disc is pressure sensitive. You load it, you trigger what's called matrix metalloproteinases inside the disc. Those things will start to degrade disc tissue, start to break it down, leading to what's called a catabolic destruction of the tissue. That will excite pain fibers and pain chemicals, right? Cytokines and inflammatory processes will begin. This is the trigger of back pain, right? You look at it and go, oh, my disc is bad. Well, why is your disc bad? It's because you've been like this for years. Your body can't tolerate for long periods of time the entire trunk to be off midline. You got to realize the person is standing like this, they're sitting like this, they're trying to walk and move from this position. This creates problems. Okay, so this study looks at this condition. We're going to take people with chronic mechanical low back pain, no leg pain. We're going to have some exclusion criteria that I'll go through, and we're going to look at this issue and come up with a treatment procedure or process for these subjects over a course of time, and then we're going to compare it to a true control group, a natural history group. Okay, so this is going to be a non-randomized clinical control trial. Subjects are going to self-select what group they want to be in. That's why it's non-randomized. Some people don't like non-randomized trials. They go, oh, there's bias in there. You know what? Non-randomized trials are exactly what matches a clinical situation. A patient comes to any provider and they either say, yes, I want this, or no, I don't. So the reality of these non-randomized trials, we did this because it matches the actual patient situation and scenario in an active practice. It doesn't matter if you're medical doctor, PT, or chiropractor. This is the reality. Patients will choose what they want to do. You don't force them into a control group or a treatment group. They self-select. So 63 prospective consecutive patients that volunteered to be in the treatment group were compared to 23 prospective volunteers that volunteered to be in the control group. They did not want care. Both groups had chronic low back pain and lateral trunk translation postures. Now in the treatment subjects, we're going to do initial and then end treatment follow-up examinations and x-rays. We're going to look at simple pain scales in this project. We did not do disability index. We did a numerical rating score from 0 to 10. 10 severe, bedridden, 0 means no pain. We're going to do AP lumbar x-rays, and we're going to look at people's posture, and we're going to look at the outcomes after an approximate 11-week treatment time, an average of 36 visits. Roughly 3 times a week. So 3 times a week of treatment, and we're going to look at a roughly 11-week treatment outcome, so 36 visits later. Now before we do the re-examination, there's a minimum of 1 day with no care. Most often it's 2 to 3 days. For example, the patient's last visit would have been on Friday, and then we reevaluate them after the weekend on Monday. Okay? Control subjects, no treatment. They're going to do what they did before they came in. We have an initial exam and x-ray, and then they're going to choose to just self-manage like they've been doing. We're going to reevaluate them 37 weeks later. Now, why 9 to 10 months later? Well, the longer we follow this control group, we can see, did their pain change at all? And the reality is, you'll see what we found, right? It did not change over the course of 9 to 10 months. Exclusion criteria. We don't want to look at radicular symptoms. We're not talking about true foraminal stenosis and disc herniations here. These subjects can have disc injury, but it's a contained disc injury. We don't have a herniation of the disc per se that's affecting the leg, right? Now we don't know, did the subject have any herniation? We didn't have MRIs, but we do know they didn't have leg pain that would be radicular in nature, no sensory and motor deficits, right? So no, touch and no muscle strength deficits for a patient out there. No central canal stenosis, so no neurogenic claudication, things like that. No compression fractures at any level, no prior surgery. Moderate to severe degenerative changes in the discs were excluded, in particular in the mid and lower lumbar spine. And then also, anatomical leg length inequality greater than 10 millimeters were excluded in this project. Why? Well, with a large, short leg, that itself creates a trunk translation posture, and that's a confounding variable that we want to remove. We're not looking at true anatomical leg length inequality, at least greater than 10 millimeters. Okay, so here's what we did for intervention in the treatment group. We looked at what's called Harrison CBP Technique Mirror Image methods. My dad was the first to develop these in the 1970s and 80s, and he coined the term mirror image, my late father. Mirror image, he said, hey, if you're translated to the right, let's give you a treatment to translate it to the left. So this is our exercise. The subject's going to either do a seated exercise, controlled to take the pelvis and legs out of it, translate their trunk over against resistance, holding for 3 to 5 seconds and then relaxing back to neutral. And then repeat this process 50 repetitions per session. We can also do this standing. And sorry about how excited the model looks there. There's a lot of photographs going on. I always wish the model would smile, but this is the best photograph that I had of this particular individual. By the way, I'm not supposed to tell you that's my younger sister. She always gets so mad at me for showing these, but I'm going to show it anyway. Hi, Stephanie. Stephanie's doing a trunk translation there. Smile, Stephanie, please. She's translating her rib cage over to the left side against a thoracolumbar resistive band. We're standing here supporting the pelvis and the leg with a block, and we're controlling that movement again, 3 to 5 second holds, holding it or repeating 50 repetitions. So we did exercise. Also, what was called mechanical assisted mirror image manipulations. In this example, we're showing a drop table setup. If the trunk is translated to the right side, we're going to lie the person on their right side, put a block of different sizes for comfort. You know, if you have a lot of pain, we use smaller blocks. If you have, less pain, we'll use larger blocks as you get used to this. We'll put the block under the right lower rib cage and translate you to the left, and then we're dropping down using a drop mechanism. And by dropping down, I don't mean it's an aggressive drop. It's a gentle drop that's rapid using what's called a drop piece here. The piece elevates up approximately 1/8 to 1/4 inch, and then when we push, it drops down. It creates a rapid vibration into the joints, and it helps reset postural balance in the nerves, right? And in your brain, in the nervous system, there's a center called the vermis of the cerebellum that influences postural control and postural balance. And the idea is these postural adjustments or postural manipulations, what they do is they trigger a resetting of the cerebellar sense of balance of three-dimensional posture. At least that's the theory, right? So we're doing this 1 to 3 times per session, 3 times a week on our drop table. Also, short-term acute care, or what we would call in CBP technique acute relief care for the first 2 to 3 weeks. Now, I don't mean acute back pain. I mean acute relief care. We classify it as when we do 2 to 3 weeks of spinal adjusting at those joints. So also like a diversified style spinal manipulation was done regionally, not at the segmental level, for the thoracolumbar and lumbosacral joints, and that picture's not shown here. And sorry about the semantics. It's not acute back pain, but we call it acute pain relief protocols, just to give subjects some initial movement in their joints so it's not so uncomfortable when we do these procedures. Also, what was done was what was called lateral translation. We used what's called the Berry translation table. The originator of this translation table is Dr. Bob Berry up in New York. This is a laying down table that we lie the person on their back, and we can slide the pieces underneath the rib cage or the head left or right, and also bend left and right to create either bending or translation movements. Now, in this particular project, we did translation movements. So you can see that the torso is translated to the right side relative to the pelvis. We start this translation in traction for 1 to 3 minutes, and we progress up to 10 minutes. We call this translation traction. It is not distraction or stretching on the long axis. It's stretching into lateral offset. So we call it translational traction. This is where we stretch the soft tissues, the muscles, the ligaments, the discs. We stretch them in the mirror image into their new position. Okay? So these are the procedures that were done in the treatment group. Now, the results in the control group, their pain in X-ray actually worsened. Right? So the pain in X-ray actually got worse. Okay? Or excuse me, at least the X-ray worsened. We'll look at the pain outcomes. However, there were statistically significant improvements in the treatment subjects' pain scores and lateral translation. We'll look at that. Approximately a 50% improvement in the translational distance on X-ray in these subjects. So the control subjects stayed identical with their pain, but they increased their translation displacement over time. So the natural history is it gets worse. Okay, in control subjects, when you do nothing, it gets worse. We'll take a look at that. Contrast to the treatment subjects, we see a positive effect in pain and alignment of the spine and posture. So here's the AP lumbopelvic radiographs in the control subjects, 23 subjects before and after, 37 weeks later. Here's their translation, 7.2 millimeters, 9.6. That's a 2.4 millimeter worsening. That reached statistical significance. Even though it's only 2.5 millimeters, it's statistically significant. So the natural history of this is it gets worse over time, okay? Their angle stayed roughly the same. So the mid-low back angle stayed the same. No statistically significant difference. You might go, well, the number's different. No, it's not statistically. The lumbosacral lower low back angle is no difference. The sacral base angle, the horizontal, is no difference. Okay, contrast that to the treatment subjects, and what we identified is the treatment subjects here, 63 treatment subjects. Their translation distance improved by 50%, 15 millimeters to 7.3 millimeters. We'll look at the angle measurements coming up. Here's their pain. Here's their pain. Look at the treatment subjects. They started out a 3 out of 10. They're down to a 0.8. That's a 73% improvement in chronic back pain. Look at the control subjects, 3.9, 3.8. There's no statistically significant difference here between the pain initially in these subjects. However, at the follow-up, there is a dramatic significant change, p.001 less than, in the, showing improvement in the group that got treatment. What that means is the natural history of back pain is it stays the same. I'm sorry. It's not my fault. It stays the same. If you do nothing, nothing will happen. It doesn't get better. It stays the same. Patients need to be made aware of that. It's not just going to get better on its own. 9 to 10 months later, look, they were a 3.9. Now they're a 3.8. It's no better. It's no better, right? It's no better, just like the other studies in the literature showed. Contrast that with the treatment. We're showing an improvement in the natural history of the pain, at least after this 11 to 12 week treatment program. 36 visits later, your pain is now very, very minimal. It's 0.8 out of 10. Okay, 0.8 out of 10. It started mild to moderate, and now it's considered slight, right? It's 73% improved. Here's the x-ray changes. The trunk translation went from 15 down to 7. That's a 50% improvement. Now the angles are slower to change. Okay? For whatever reason, we actually do know why, but we're not going to get into it in this particular project. The angles are a little slower to change. It takes time for that spine to start to straighten out in the mid-lumbar spine. Okay? But you can see it is improving. It's improving by about a third. Okay? The lower low back angles are improving. The lower sacral base angle is improving. All these x-ray measurements show the treatment had an effect on this translation posture as measured on the x-ray. We can improve the alignment of your spine in 63 subjects by 50% in 36 visits. Okay, you might go, wow, that's not very much. Yeah, it is. It's a lot. It's 50% better. Hey, you know what? You've been like this for a number of years. It's going to take time to retrain your muscles, your ligaments, your discs, your nerves. Your body has a sense of, I like to be here. Even though it's not good for you, it's like, this is where I'm used to being. It's not good for you. It's breaking down your body. You've got to retrain that, re-educate it back the other way. It's just like dietary changes or lifestyle changes. They don't happen overnight. It takes time for your body to adapt to those things. You know, you don't lose 100 pounds in 3 months. It might take you a year to lose 100 pounds. This is the same concept. Here's before and after x-rays in the subjects. You'll notice we're improving the alignment of the spine as a result of this treatment. Again, this is not acute antalgic types of spine displacements. This is chronic low back pain, trunk translation. Now, this is a very large change. Sometimes subjects will get way above the average change. Other subjects get a little less than average. There's always a bell-shaped curve. Most of the subjects, 2/3 of them are going to be real close to 50% better. Some of the subjects are going to be near all the way better, and then other subjects, they might only be 10 to 25% better. Okay? Just showing you a few of the before and after x-rays, right? Now this one does show some, considerable osteophytes, but it was only at the upper lumbar levels. It wasn't what we would call moderate to severe degeneration. The discs were still relatively intact, so we included this subject in. And there was no leg pain, right? Look at this subject. 27 millimeters down to 17 millimeters. Not quite 50% better, but it is better, right? This one is less than the average change. Look at this subject. 22 millimeters offset down to 9 millimeters offset. We're slowly starting to improve this one. This one's better than 50% difference. Okay, conclusions. A new type of lateral translation traction combined with postural mirror image exercises and drop table mirror image adjustments, aka CBP technique, chiropractic biophysics technique, produced significant X-ray changes in the AP lumbar spine and positive changes in their lateral translation posture, as well as positive changes in chronic low back pain. Specifically, these subjects were 73% improved. Following treatment, an approximate 50% improvement was noticed in these postures. Compare that in contrast to the control group, no change in their pain and a statistically significant worsening of their posture at 9 to 10 months. Okay? Study limitations. It's not a randomized trial. We didn't randomly allocate subjects to what group they would do. So there can be an inherent bias effect where the subject is more willing to participate or do something to change their behavior, right? However, this represents the reality of a clinical situation. Other types of limitations. There's no long-term follow-up on this. We did not do a 6-month to a 1-year follow-up. So this is a limitation of the project. We don't know, are these people maintaining these 73% improvements at the long-term follow-up in their chronic pain, right? We don't know that. That remains to be studied. However, we do know this. If you compare our trial to existing trials on similar subjects using just chiropractic spinal manipulation or osteopathic spinal manipulation for chronic back pain, those studies that only look at randomized trials on chronic low back pain outcomes using spinal manipulative therapy, which was used in our project, but if we isolate that out and look at the literature, those subjects only report about a 40 to 45% improvement in their chronic back pain. In this project, we reported a 73% improvement in chronic low back pain. Thus, we think that this study has impact. It's improving chronic back pain by a greater magnitude, intensity-wise, compared to standard spinal manipulative therapy. However, because we did not have a group that only got spinal manipulative therapy only, we don't know how much of the pain improvement in our population in this project was due to the intervention of spinal manipulation that was provided in the first 2 to 3 weeks. However, again, comparing it to the literature, we noticed almost a 50% greater improvement in chronic back pain intensity in our population compared to what's identified in standard chiropractic studies, right? So we believe that this study has impact. When you look at people with chronic back pain, oftentimes they have these mechanical translations of their trunk. We need to start doing something about these. People need to be taught and educated that they need to do something to correct their posture. We believe that this is one of the long-term reasons why their pain does not improve. Now again, that remains to be seen and tested, but I would be willing to bet that that's going to be found in the future in outcomes. Other studies looking at other types of postural patterns have identified in the sagittal plane that that statement is true. We need to identify this in the coronal plane, so this again is one of the limitations of the projects. That brings us to the end of the research presentation for this week. Hopefully you enjoyed this particular project. I would really love it if you would go to CBP Nonprofit, our website, and consider funding some of the chiropractic and spine research projects that we do. We actually do need your help to look at future studies addressing some of the comments that I went through at the end. Also for patients, if you're out there, if you can look in the mirror at yourself and identify that you have a trunk translation and you have a chronic condition, you need to do something about this. You need to get in and see a CBP trained chiropractor. There is hope for you. Don't go, oh, I've tried everything. No, you haven't tried everything. If your posture still looks abnormal, you haven't done the right things to correct this. Get yourself into a CBP trained chiropractor, get an evaluation, and consider getting proper, treatment dictated and directed at correcting your spine. I guarantee you, for the most part, people will respond to that. There's always cases that don't, but the averages are they get better, and so will you. go to cbppatient.com and look up a CBP trained chiropractor. Until next time, I'm Dr. Deed Harrison. Thank you for your time and attention.